Welcome to the Clinical Care Options Podcast, Disparities in the Management of Lupus and Lupus Nephritis. I'm your host, Craig Borders. This, the second of two podcasts, will focus on disparities in the prevalence and management of lupus and lupus nephritis, why those disparities may be occurring, and what healthcare providers can do to address them. Joining us today are Drs. Karen Costenbader and Brad Rovin. Dr. Costenbader is professor of medicine at Harvard Medical School and director of the lupus program at Brigham and Women's Hospital in Boston. Dr. Rovin is professor of medicine and pathology and director of the Division of Nephrology at Ohio State in Columbus. For more information about Drs. Costenbader and Rovin, and for a link to the full online educational program, including an on-demand webcast and downloadable slides, please visit the link in the show notes for this episode. This program is supported by an educational grant from GlaxoSmithKline. Let's get started. It's my pleasure to turn things over to Dr. Rovin.
Hi, Karen. After our lecture series, we've had a lot of questions on disparities in lupus and lupus nephritis, and I think we should go into detail on some of them. So let's just sort of kick this off with maybe you could just talk a little bit about the evidence of disparities in the prevalence of lupus and lupus nephritis in our patient population.
Yeah, hi, Brad. Well, I'm glad that there's interest in this topic because it certainly is an enormous problem. There's overwhelming evidence of overwhelming disparities in lupus and lupus nephritis. You know, the basic epidemiology is that the peak incidence of disease is young, between ages 15 and 40, and over 90% of cases are in females. And the highest prevalence is really in all non-European ancestry populations, maybe around the world. But in the United States, we see very high rates of both prevalence and incidence and severity and poor outcomes in African Americans, Native Americans, Hispanic, and Asian American populations. There are recent data from the CDC that the prevalence is about 1 in 500 among Black women, and that's really not that rare, I think, in the United States. Pretty recent data on mortality in lupus is pretty alarming, that lupus itself is one of the number 5 and number 6 for Black and Hispanic women, respectively, age 15 and 34 in the United States. So that's horrible. I mean, lupus is among the leading causes of death for young women in these populations, is just a very alarming statistic. And we see also disparities about where lupus is and lupus nephritis is in the country. When we look in nationwide Medicaid data, we see many more cases. 40% of the lupus nephritis cases in the country occur in the U.S. South. That's where there's a large African American population, but we've also seen that outcomes are worse in that population. So yes, there are alarming disparities in lupus that are really multifactorial, and I'm glad we get to discuss them today.
And just, lupus nephritis is no different in patients who have non-European ancestry. The disease severity and the disease course seems to be worse. Patients who have African ancestry, for example, and not only in the United States, but in Europe as well, tend to have a higher incidence of end-stage kidney disease requiring dialysis or transplantation as a consequence of their lupus nephritis. So yes, this is a key problem. So Karen, thinking about this then, what do you think about reasons for these disparities, and maybe focus a little bit on socioeconomic factors?
Yeah, so this is really a multifactorial problem. It's not just genetics. I think genetics and underlying genetic predisposition probably plays a role in lupus in general and lupus nephritis and some of the disparities. But I think that the exacerbation of these disparities really comes down to a lot of the social determinants of health. We saw in Medicaid again that the prevalence of lupus and lupus nephritis was highest in the zip code areas that had the lowest SES, socioeconomic status, even after adjusting for multiple other factors. So, where you live was important in getting lupus and lupus nephritis beyond your age, sex, race, ethnicity. And when we think about all these social determinants of health that my hospital we're trying to collect more of, I think they're very important in determining health outcomes. There's healthcare access. which is, access and quality and timeliness and prevention. And we've seen in lupus nephritis and new onset lupus nephritis in the country that there are unexplained disparities, large disparities in healthcare access and timeliness of really the care that everyone should get for lupus nephritis, including starting on hydroxychloroquine, starting on immunosuppression, starting on ACE inhibitors and ARBs. And these are unexplained, and they vary by race, ethnicity, by area level SES, by insurance status as well across the country. So we really need to up the playing field and get everyone access to the highest quality care, and that's hard. But then there are also these other socioeconomic factors that complicate and maybe lead to lupus. I think some of our research in the Nurses' Health Study and the Black Women's Health Study has shown that some of these factors are related to the susceptibility to lupus, to the risk of ever developing lupus, including obesity and alcohol intake and smoking and dietary quality we've looked at and exercise. And we put all those together. And we found that in the Nurses' Health Study, there was greater than 40% of the risk of lupus, the population attributable risk, could be explained by personal social behaviors in the healthy lifestyle score. So really, I think that we have to work about on those and getting everyone into a physical environment where they can exercise, where there are green spaces, where there's less air pollution. All of these things are probably very important. It's so multifactorial that we have to work on multiple fronts at the same time.
I agree. And just to highlight a particularly interesting biologic variable in patients of African ancestry, we now know that there's a certain gene called APOL1 that has variants that have been selected for in patients of African ancestry because they helped in the past in infectious disease. But this also seems to increase the susceptibility of progression toward end-stage kidney disease in patients if they have lupus nephritis. So this is a very complex interplay between environment, society, and genetic background that I think there's a large interest in research right now in the community. Thinking about things we can do to sort of get people treated well, what about the role of adherence in disparate outcomes?
Yeah, well, that's a tough nut to crack. I think that you and I have talked about this before, and we really think that a lot of the prediction of poor outcomes in lupus is explained by non-adherence, and non-adherence is multifactorial as well. There are many reasons that people do not take their medications as prescribed. There's access to care issues. There are barriers with health insurance. There are barriers with medical literacy and understanding and having shared decision-making conversations so that patients know the risks and side effects and the severity of their disease, and they understand, at least have some kind of evolving understanding of how severe their disease is and why we're asking them to take very toxic medications or potentially, toxic immunosuppressive medications. I think that people also have a limited bandwidth, and that's been really highlighted during COVID. People have a lot of things going on in their lives. They have work, they have kids, they have really big problems. And then asking them to deal with a chronic illness and come to multiple appointments so we can check all their labs or go to infusions, really complicates things. So yeah, there's so many reasons that people don't take their medications as prescribed. I think that we have to have, lots of frank conversations, and people have to understand us. I think doctors tend to use big words and medical jargon and talk quickly, and people have no idea what they actually just heard, and they're very confused and they're worried, and they may only seize on one word, like the idea of I could go blind. So some people hear that, which is not a good way to introduce potential toxicity of hydroxychloroquine, but when they hear that it could have something to do with their vision and they have to get their eyes checked, some people run scared. So we have to know how to talk about the risks and benefits of medications in ways that patients can understand. And then there's the flip side of people. I think this probably happens a lot in lupus nephritis, that some people with lupus actually feel pretty well. They don't, proteinuria doesn't hurt. So it's hard to impress upon them how severe their disease is and how they could lose their kidneys and why they should take their medications. And some people with, even if they've had bad lupus before, when we get them feeling better, they think it's over. They think it's done. And maybe they don't need to take these medications anymore. And so they kind of self-discontinue their medications.
So, Karen, I agree with everything you've said. And I'll make two comments here. One is, one of my thoughts about adherence is that the medications we use have such significant side effects right up front. And I'm talking about glucocorticoids, that it may suddenly be off-putting to patients once they start on these medications. And one of the things that I think might improve adherence is that in the newer clinical trials, we're actually trying to decrease glucocorticoid dosing as well as taper these medications much more quickly. And I think that may help. And the same considerations should be thought about for these new medications, because they generally tend to have fewer side effects and are pretty well tolerated compared to a lot of the medications that just generally suppress the immune system that we've used in the past. So I think we may be seeing some light on that front in terms of adherence. The other thing you brought up, which I think is key and critical, is the communication issue. How do we communicate with patients in our clinic? And I know that this really is an effort that we have to sort of realize, and it isn't, at least in my clinic, it's communicating both to the patient as well as to the patient's family, because this is a disease that affects not only the patient, but also affects the entire family dynamic because of all the things you said that need to be done to treat this adequately. And so I think communication is really important in dealing with our patients and helping them understand the importance of taking medications. So thinking about that, it sounds like at the Brigham, you've got some nice ideas about support groups and facilitators. I think this is really a novel way of approaching patient and physician interaction. Why don't you tell us a little bit about that?
Well, we do. We have some initiatives going, and definitely we need more. And I think we need more across the country. The Lupus Foundation of America is also working hard in this area. The American College of Rheumatology is. I think there are a lot of things going on. I couldn't agree with you more about communications. And I think that doctors, we get 20 minutes for a follow-up appointment, and we're in a rush, and we're using big words, and we're talking fast. And it's hard for us to assess. Well, we're very poor at assessing patient adherence. Patients don't want to tell us if they are not really taking their medications. And that's been shown in many past studies. And we don't have the bandwidth. We need to be better at it, but we're really not very good at assessing the social determinants of health, of finding out more about our patients and what's going on in their lives and all the factors that may be affecting them that can influence whether they can take their medications, they can come for appointments, they can do all the things of getting their eyes checked and going to physical therapists and all the things that we ask people to do. And I think, regular follow-up is the first thing. If you can get people to come in at regular intervals and get to know them over time, in rheumatology, and I think in nephrology too, that's a nice side of longitudinal care. Over time, you get to know people. And at the Brigham, so we have what's called an integrated care management program here that's been expanded specifically to include lupus and lupus nephritis patients at high need. So patients who are using a lot of emergency room visits, and were getting admitted a lot and just using a lot of healthcare resources outside of regularly scheduled outpatient appointments. And now they're in this integrated management program with nurses and nurse practitioners really supervising their care, making sure that a lot of their social determinants of health, their housing, their food stamps, their other things are taken care of as well, so that they can get their labs done, and hopefully that will improve care. And it has been shown to improve care in other diseases and in lupus and other settings as well. We also have peer support group, which is run by our patients and supported by the Lupus Foundation of America. And I know that the LFA also has peer support programs that all moved online during the pandemic, but I think that makes them very accessible to patients across the country. And there are male-only LFA peer support groups, and there are African-American groups and Asian-American groups, and younger patients with newly diagnosed disease. That talking to other patients with the disease, they can learn a lot from each other and they can help support each other.
So, Karen, I do work with the LFA, as you know, as do you. And I did participate in one of these support groups online. It was, A, it was a lot of fun, but B, they asked me to talk about how the new drugs work, the 2 new drugs that were just approved. And so I made slides, and these were not the sort of slides I would present to basic scientists, but these were slides that regular people could understand about how these drugs work with the immune system. And it was a really amazing experience because I don't know that most patients ever talk to their doctors about how the drugs work and why they work and what the side effects may be because of what the drugs are doing, et cetera. And I had a flurry of questions from interested patients after that seminar. So I think that's another way we as lupus physicians can get involved, is to help participate in these seminars and help educate patients. In my opinion, an educated patient is generally a patient that's going to do well and understand why we are asking them to do things that they might otherwise not really enjoy doing. So let's wrap this up. Karen, there's a big need on having diverse and representative populations in clinical trials to test new medications. How have we been doing in that front?
Unfortunately, we're working on it. That is definitely a big problem. I think it is hard. It has been hard to get the right people basically into the clinical trials. We need clinical trials that test new medications in the populations that are most affected, as I started out reviewing, and that those have not been the populations who are enrolled in our clinical trials. And even the most recent clinical trial, or one of the most recent clinical trials of iberdomide, recently published in the New England Journal of Medicine, I think they only had 7% non-white patients. So that is a big problem. I think there are many initiatives outreaching. GlaxoSmithKline had an entire study of belimumab in patients of African descent, and they used many different strategies to outreach to this population because it's so important. We need to know if the medications work in the people who are affected. We had a conference, a 2-day conference, which went really well right before the pandemic in October 2019 in Bethesda, and we had representatives we had a lot of patient representatives, we had people from industry, we had people from the FDA and the NIH and the CDC talking about cultural sensitivity and how to enroll in clinical trials and medical literacy and all the different issues that need to be addressed, and really outreaching to the communities that are in the South, as I mentioned, where they have an enrichment of lupus and lupus nephritis, and throughout the country to try to increase enrollment. Lots needs to be done there.
Yeah, and I pick up on one point, which is sort of the idea of a patient navigator. People who are from the affected communities who may have some knowledge of lupus from their own experience or own family experience can actually be of great benefit in helping us interact with a diverse patient population and reassure them that what we're doing and trying to do with clinical trials is develop medications that will be effective for all our patients. Well, I think our time's just about up. I know this is just touching the surface of disparities in lupus and lupus nephritis, but I think it gives the audience a flavor of sort of where we are now, and really, more importantly, where we need to go with this topic. And again, this provides a lot of food for thought for clinical investigation for all of us who are interested in patients with lupus. So thank you all.
Thank you. I agree. Lots more to be done.
Thank you, Drs. Costenbader and Rovin. Be sure to tune in to our previous podcast, in which our faculty discussed frequently asked questions about the evaluation and management of lupus and lupus nephritis. As a reminder, to view the full Lupus and Lupus Nephritis Improving Outcomes and Reducing Disparities program, click on the link in the show notes for this episode. And be sure to check back regularly or episodes on other important topics in immunology. Thank you.